Hi. Thank you for joining the Head and Neck Interactive Cases. So I don't think there's an audience response, but please feel free to just raise your hand or ask questions or let me know what you think. I'm going to present several cases, and for each case, there are different approaches that I will present because coming from different institutions. So I was trained at MD Anderson, and then I practiced at Memorial Sloan Kettering for 8 years. Now I'm at Princess Margaret. So there are certainly a lot of different approaches for a given case. So this is what I'm going to go through. Okay, so for case one, it is supposed to be very straightforward. It's a 54-year-old man with a history of smoking and hoarseness. The initial scope exam showed a left laryngeal lesion suspicious for left larynx vocal cord cancer. Biopsy confirmed fragmented squamous carcinoma. And here's the next CT. So everyone can see that there is a left, so it's hard to see the true extent of invasion, right? But you can see that there is a left larynx cancer in the left true vocal cord, probably with a little bit of invasion to the false vocal cord as well. There's a little bit of also invasion into the anterior commissure. So what are the treatment options for the T2N0 for radiation? So we're talking about radiation, not other options. So traditionally, before the IMRT, we would do a 5x5, right? The field for T2 probably 6 centimeter. So with the extension of up and down. With the invention of IMRT, we started contouring out the carotid arteries to try to avoid the doses. And this is one of the most commonly used approaches here. This is one of the regimens at MD Anderson. So you contour the GTV, the gross tumor volume, and then the CTV1 is the gross disease plus 8 to 10 millimeter margin surrounding it. But eventually the CTV 2 and 3 will cover the entire larynx. So that's one of the approaches. I'll show you the dose distribution, but feel free to raise hands because each institution does it very, very differently. So for this case, there are also several dosing regimens. How many people here use the 250 centigrade per fraction for 25 fractions, the Japanese regimen? Anyone? You? All right, so that's the regimen that Sloan Kettering uses. There are other regimens that people here for T1 or T2. So this is listed here. Sort of hypofractionation, 66 gray in 30 fractions. If you are giving concurrent chemo, then 60 gray in 33. Post-op, that's rarely done, 60 gray in 30. So I want to show the dose distribution here. You can see that you contour you contour the GTV, and with the higher dose, the 66 gray here on the left side, you do spare a little bit on the right side with a lower dose in the 50 grayish. The goal is to spare the carotid artery contralaterally. So that's one of the approaches. The green is the GTV contour. So if you use this approach, you at least need to do a daily KV or even daily cone beam, depending on your margin. So that's one way of doing the very simple, straightforward larynx case. Okay, so I don't know if that's the way that everybody does it for the larynx, or do you have actually the same dose for the entire larynx? So who does the dose gradient for this kind of early stage larynx, and who does the dose gradient? Please raise your hand. No? Okay. And then who does the same dose for the entire larynx, like 66 gray? Okay. Okay. So you can see that there are definitely different approaches here. And so that's one way of doing it. And you can see that's just, okay. So another method that I just have recently started doing after moving to Princess Margaret is that you really, really try to spare the other side of the larynx. So when you contour, so this is obviously a different patient, but also on the same side for a T2 and 0 larynx case, definitive radiation. You contour the GTV in red, and the CTV, you put typically a 0.5 or a little less centimeter margin of the CTV1, and then you're covering this whole area on the left side, but you really try to spare the right arytenoid. I think that's where you can probably spare some toxicities and also laryngeal edema when you try to spare the contralateral larynx. So that's the approach of Princess Margaret. You can see the margin is tighter now, SUP and INF, but this is with daily cone beam CT. So this is the dose distribution. So I find it very interesting that you actually really are sparing at least one side of the arytenoid. And I found that the patients are doing actually pretty well with this approach. Because usually for larynx patients, most of them, they get by toward the end with some pain medication, right? But what you're really seeing here is that the patients actually are tolerating more oral diet with the pain management. And for here, the regimen they used at Princess Margaret is 66 gray, 33 fractions, the Hanka for T2. Okay, so I know everyone is a bit different. So this is another method. At Memorial Sloan Kettering, that will be 65 gray in 26 fractions at 250. So it's another dosing regimen. So this is just a very simple case, but two different approaches that I find very, very interesting. Any question before I move on to the next? All right. Right. All right, so the next one is the nasopharynx. That everyone here should be expert of because we see so many in Taiwan. This is a 55-year-old man with a 3-month history of left ear fullness, epistaxis, and nasal congestion. 20-pack year smoking history. So the MRI unequivocally showed a very significant nasopharyngeal cancer here, occupying the entire, let me see, you can actually not see my pointer, so I have to use this. Okay, can you see it now? Okay, right? Okay. Okay, so occupying the entire nasopharynx and parapharyngeal space. And then with the left Falstaff-Rosenmuller, obstruction, and onto the right, to the midline, the right Falstaff-Rosenmuller, and then parapharyngeal fat. And then you can see that right here, probably invasion to the left palate as well. Okay, so this is a very, very advanced stage. Okay, right here. Biopsy showed understandably invasive squamous cell carcinoma, EBV positive. PET-CT showed no distant metastases. So it's a T4, N2, nasopharynx cancer. So I wanted to ask, how many of you here do the induction chemo? I think it's probably everyone will start doing the induction chemo, right? And when you do the induction chemo, do you, so okay, let's see. So do you, after the induction chemo, do you treat the post-induction chemo volume to 70 gray or you treat a pre-induction chemo volume to a different dose. I'll show you what we usually do. Okay, so this is the pre-induction. So I have to say, in the US in Canada, people actually don't do induction that frequently. So most people actually, if for this patient, if there is no impending airway obstruction or intracranial extension or impinging on any critical structures, people actually will start using concurrent first and followed by adjuvant. So I know the practice patterns are very different comparing to different regions. So that's what we did for this patient. So I will try to attempt to draw GTV here, and then the CTV1 and CTV2. So, all right. So the GTV is obviously the gross tumor, and there are two ways of doing it, and I'll show the Memorial Sloan Kettering method. So when we draw the GTV, this is the 70 gray or 6996 gray. And then we typically do a 0.5 centimeter expansion. There is no CTV when we planned it. So if we do a 0.5 centimeter expansion, and then we, oops. All right. So if we do a 0.5 centimeter expansion, just bear with me, and then we will expand to cover the entire clivus. So just pretend that this is 0.5 centimeter expansion. This will be the PTV 70, okay? So there is no CTV 70. So there will be the PTV 70. And then there will be a CTV 60. So there will be only two doses. GTV and PTV 70, and then the CTV 60, or like 59, 96, something, in 33 fractions. So the CTV, obviously you will want to cover, so let me just draw to a different one. Okay, so for the CTV 60, you want to cover the posterior 1/3 of the maxillary sinus, 1/3, 1/3. So this will be the CTV 60, okay? We want to make sure that the CTV 60 at least covers additional 5 millimeter from your PTV, okay? And then the CTV 60 to the PTV 60 is additional 3 millimeter margin if you use the daily KV and weekly cone beam. So it's the same here. And then for the lymph nodes, how many of you treat the level 1B if, so how many of you treat the level 1B? No, nobody, right? Because you treat the level 2 through 5. So that's the same approach. So whether they're involved or uninvolved, levels 2 through 5 and RP. At Princess Margaret, they still treat level 1B bilaterally, which I find it to be very toxic. So we are reviewing our regimens right now to make sure that we are sparing level 1B, especially for nasopharynx. So that's one difference. And then I will move to one interesting, so I'll spend more time here talking about oropharynx. I know that we don't have that many HPV-associated oropharynx patients in Taiwan, but I know that the number of patients are also increasing over the years, and you will see more and more. And I think it's very interesting to see that the treatment paradigm has shifted so much, and there are so many different ways of doing it. So you can see that this is a 45-year-old man, non-smoker, and where you can see a left tonsil mass. CT scan again show a 1.5 centimeter left tonsil mass confined to the tonsillar fossa, one enlarged left level 2 lymph node, no other lymph node. And then PET scan did not show any metastases. Biopsy showed a P16 positive squamous cell carcinoma. Okay, so the TNM category is different for the HPV positive oropharynx cancer. It's less than 2 centimeters, so it's T1, and then only one lymph node, so T1 and 1. And how many patients here? So I will present different situations. For the T1 and 1 HPV-related oropharynx, many patients would undergo torus surgery, and then ipsilateral neck dissection if it's well lateralized. So the patient underwent torus and left neck dissection, 1.8 centimeter squamous cell carcinoma, margins negative, very wide margin, one lymph node positive as expected, no extracapsular spread. So the pathology is still T1 and 1. And in this case, T1 and 1 well lateralized, a very wide margin, one lymph node with a good number of lymph nodes removed, 26. How many of you would observe and no adjuvant radiation? All right. And then how many of you would do adjuvant radiation, 60 gray, ipsilateral? And what about adjuvant radiation, 50 gray? All right. Yeah, only to the neck. Yeah. Okay, okay. So I think you can see that there is really no standard of care. So let me see if I have another slide. Okay. So for wide margin resection, 1 out of 26 lymph nodes, this patient would fall into the ECOG 3311, the low risk group for observation. So this would be that group of patients that could be observed. However, the ECOG 3311 that was published a little more than a year ago, the low-risk category, based on that paper, it showed 98% disease control at 2 years. But actually, anecdotally, there were more recurrences after 2 years. So that made people a little cautious. However, observation is still not wrong because the patient could be salvaged if the patient should recur. So in this case, I would say in most institutions, they would offer observation as one of the options, or ipsilateral radiation to either the neck or to the primary plus the neck. We really don't have any trial data, right, to see, if we can omit primary or omit the neck or both. What about 0.1 centimeter margin? So I think most people would treat the primary and the neck, probably ipsilateral radiation. And for patients with, so these are the two situations I want to discuss. For patients with positive deep margin, or with extranodal extension. These two scenarios, let's discuss it differently. So for the primary site with positive deep margin, we normally would ask the surgeons if they are, if there's additional surgery that could be done. Usually not. Usually they won't go back. So in this case, we will treat the area with the deep margin, that's positive, and also the neck. The question is, do you use chemotherapy or not? And what is the dose for that primary disease with the positive margin? Because based on the Bernier combined analysis, any positive margin or extracapsular spread is an indication for chemo. But for a treatment-naive T1N1 tumor, if you never had surgery for this patient, not many people would offer chemo, right? If you are doing radiation alone, you probably would do, the Hanka or hypofractionated or just 70 gray in 35 fractions. So why would a surgery with a positive margin automatically buy the patient chemo if the patient would not be treated with chemo RT upfront? So this is another contentious discussion every time when we have a case like this in the tumor board. For most patients, there would not be chemo. It would be 66 gray to the tumor bed because of the positive margin, and then 60 gray to the lymph node, to the neck. So that would be the treatment approach. However, if you have extracapsular spread, then we would certainly discuss chemotherapy with this patient. For some patients, like the audience mentioned about, in this case, we would consider skipping the primary if the primary is well resected with an adequate margin, and we would consider treating the neck with the chemo. So I know there are various different kinds of approaches, and none of them actually had a very solid evidence to back up. So it's all depending on the institution preferences. And I also want to bring up the elective dose. Okay, so if we are treating the patients with chemoradiation, 70 gray, what would your elective dose, CTV1, CTV2 be? You can see that these are the trials that are published, not just for HPV positive oropharynx. It's for, some of them are both HPV positive or negative oropharynx, and some included larynx and other head and neck. So you can see that there are some de-escalation trials, de-escalated the dose to the gross tumor bed, okay, so or the gross tumor. So after surgery, there could be a range of 50, 30 gray BID or 50 gray. If it's not surgery, not resected, it can be de-escalated on protocol to 60 or 70 gray. So that's the range of gross disease. What other trials did not actually specify is the disease, is the dose to the elective, right? So traditionally, the elective dose is, if we do 70 gray in 35 fractions with concurrent chemo, the elective dose is usually 63, 57, or sometimes 45 in a dose painting fashion. Nobody really studied the elective dose and like how high we should go or how low we can go down. Because as we treat these patients, although the primary dose, 70 gray, contributed the majority of toxicity, the elective dose, margin, and dose that's surrounding the primary can actually get a whole mouse irradiated and causes a lot of toxicities. But nobody really knew actually what the correct elective dose is. If we look at the history, this dose was determined in the 2D era where you couldn't really see the tumor. So then you put in a large margin and large dose gradient to cover all the possible regions. And there was fluoral simulation, so there's no CT sim, there's no PET CT sim, so you don't really know other gross disease, so you cover them with a very large margin. So this is just highlighting the huge difference, okay. So here I wanted to highlight that at Memorial Sloan Kettering, we started decreasing the elective dose in concurrent chemo RT patients for the oropharynx treatment because we found that the the elective dose of 60 gray or 57 gray really, really caused a lot of toxicities. But we also know that we cannot just randomly decrease the gross disease dose to 70 gray without putting the patients on trial. So in order to lower the toxicities, we try to decrease the elective dose so that there's less dose and less field in the, being treated in the 50 to 60 gray region. So this is the regimen that we started doing since 2017. I'll present the result. So the primary site, the GTV 70, it's still 70, okay? So we are not decreasing the primary site dose. But for anywhere that you would normally contour CTV1, CTV2, CTV3, there's only one dose, that's 30 gray. So everything else is 30 gray. Gross disease is 70 gray, so that's not changed. But everything else is 30 gray. So normally, other doses that you would use, there's only 2 doses. And then we also reduced the margin. So as I mentioned, we went from GTV 70 directly to PTV 70 with a 0.5 centimeter margin here. So there is no CTV 70. Then gross lymph node, the same, GTV 70, then no CTV 70, and then GTV plus 3 to 5 millimeter expansion to PTV. So that decreases the extent of the 70 gray by using daily imaging to make sure that the setup is correct. For CTV 30, it's just everywhere else that you would normally cover. So the high RP, levels of 2 to 4, that's gonna be 30 gray. So it's delivered in 2 phases. The first phase is 30 gray in 15 fractions to everything. Then cone down, additional 40 gray to the GTV 70, the PTV 70. So there are only 2 dose levels. This method was initially published by us in a few years ago, 2018, after we started doing that. So here we wanted to show you a few examples of what we did. So the red is the GTV 70, is the primary tumor, okay? And the yellow is 30 gray. So you can see that whatever you wanted to treat previously, for higher dose, it's 30 gray. Sometimes, initially, when we started this regimen, people feel a little uncomfortable going from this red to yellow, 30 gray. So initially, we did a 50 gray around the primary tumor for a few months. So that's how we initially outlined the tumor. We had a PET-CT SIM, and also the MRI, so make sure that we covered everything. So you can see that the neck is treated to 30 gray. So the advantage of this is that you really spare the parotid doses, because the parotid mean dose usually is 26, right? So you can easily achieve that, or even more, if you don't have any other high dose nearby contralaterally. So that's one of the methods. Then you could see that later on, everyone adapted to do this regimen without the intermediate dose of 50 gray to the gross primary disease. So the red is the primary disease, primary site in lymph node. That's 70, that GTV 70. And then the CTV 30 is just everything else. So that's 30 gray. There are all these blue 50 because sometimes we don't know whether these lymph nodes are real or not. And previously, all these areas got 56 or 63 gray, right? But since we decreased the elective dose to 30, some people are unsure. So for some people, they're unsure about a few lymph nodes. They will still put a 50 gray there. But for the most part, it's just 2 doses, 30 gray and then 70 gray. And then here you can see, again, gross disease, and then 30 gray everywhere. Okay, so that really helped the treatment toxicities in terms of managing these patients. This is the dose differences. So in the traditional sense, 70 gray, you have 70 and 54, and then 50, 45, you have all these dose levels in the traditional IMRT plan. With the new dose, 70 gray and 30 gray, you're really sparing the low dose to the lower neck especially. So I think for those patients, allow them the larynx swallowing function is better because you have less dose from the bilateral neck contributing to the central, the larynx and esophagus. We reviewed this data, and it was published in JAMA Oncology last year. We started treating these patients in 2017, and by the time we analyzed the data, there were more than 200 patients that we treated with this approach. So what about the results? Because people tend to get very nervous, right? When you go down from 50-some gray elective to 30 gray, people tend to worry about whether there could be recurrence in the elective region. So when we look at our patients, 276 over 2-year span, 8 patients developed local regional recurrence. But all of them, 7 at the primary site or gross disease that's receiving 70 gray. So all the failures actually fail within 70 gray. So meaning that that's very consistent with our clinical practice. When you treat this patient, they fail at the primary because the primary is just resistant. Even with 70 gray, it just recurred. There was no patient that recurred in the 30 gray elective, except for one. There was a missed gross disease that should have been treated to 70 gray, but that disease got 30 gray. So that's one patient it was a missed lymph node that didn't get treated to 70 gray. So there was overall no 30 gray elective failure in this population. And these are the 2-year local regional control, distant met-free survival, progression over free survival. So this is an approach. It's been standard care at Memorial Sloan Kettering. Problem with this is that people are still very concerned about adapting this. So we are actually running a randomized clinical trial right now elsewhere in Canada because at Sloan Kettering, there's no way of asking them to randomize patients to 50, 60 gray elective anymore. So when I moved to Princess Margaret, we're trying to do this approach. So we'll be randomizing the patients to different elective doses and assess the outcomes. And very notably, 6.2 patients, only 6% patients needed feeding tube. So that's a very, very low number for concurrent chemoradiation patients. Okay, so what about further decreasing the dose and coverage? So I want to actually show you the figure. There is a even more sparing approach right now for patients that perhaps, we don't need to treat all levels of lymph nodes. For example, our current approach, we mentioned levels 2 to 4, bilaterally and high RP. However, why don't we, if you don't see any lymph nodes in the T1, T2, N0 patient, do you need to treat the whole lymph node chain from 2 to 4 if the imaging is negative? So there are current trials looking at just treating level 2. If that's clinically N0 by PET or CT or MRI, then perhaps you just only need to treat the primary and one level of lymph node. So this is not yet the standard, but I think it will be very soon, that you don't need to cover the whole lymph node chain, both sides. But I know that for these patients, most of them probably go to surgery, right? We don't treat them. Okay, so what about T3 and 0? Then traditionally, definitely treat bilateral 2 to 4. However, if it's still N0, because T3, then you treat levels 2 to 3. But then contralaterally, you could potentially just treat the level 2 because there's no lymph node there clinically detected. The probability of having a contralateral level 4 recurrence should be very low, okay? And then if it's a T1, T2, N1 patient, then you would treat a high RP and then levels 2, 3. And then contralateral, if there's no lymph node, still just one level. And the same T3 and 1. Okay, so these are the same algorithms. So I think the treatment, especially the field delineation for oropharynx, is going to evolve very, very rapidly in the next couple of years when all these trial results come up, and we'll be treating very, very limited neck to spare the toxicities. Okay, I want to pause. Is there any question about this? Yes.
One patient have equivocal size lymph node in oropharyngeal cancer about 1.2 centimeter, no FDG uptake. How do you treat it, 30 grade or 70 grade?
Okay, so for both tonsils, like bilateral disease?
Just one lymph node equivocal size.
Okay, so one lymph node.
Yeah.
And
level 2.
Level 2.
And oropharyngeal cancer. So in your protocol is 70 grade for positive node and only 30 grade for negative node. So how about the equivocal lymph node in image?
Oh, the equivocal ones, sometimes we do a 50 gray. But yeah, so it will depend. For example, if the lymph node is less than 1 centimeter, but you're still a little worried because it's still big or it's still kind of pink on the PET, then we would take it to 50 gray. Yeah. And then also there's one case. So traditionally for a non-primary, it is traditionally very toxic treatments, right? Because you treat everything. But we found out with the 30 grade elective, it's actually the best treatment for a non-primary because you just need to treat the lymph node to 70 gray. Everything else is 30 gray. So it's actually very low dose to the pharyngeal axis that you're covering for the unknown primary. It's so low that people actually do very well for the unknown primary. So that's the group of patients that benefited, I think, most from the lowering elective node. So for an unknown primary, if the patient has undergone very thorough evaluation and biopsy and everything, you still cannot find the primary, then the chance of the primary failure after your radiation is actually very low. Because, you know, even in your previous practice that you treated non-primary, when was the last time you saw the primary failure after you treat a non-primary and then the lymph node metastases, right? It's usually very low. So by lowering that subclinical dose, I think this is really beneficial for the unknown primary patients. Okay. HPV positive, but we believe that it could be for HPV negative as well, because there are other clinical trials that I previously alluded to. For example, the David Scher trial at Southwestern and the Belgium trial, they both use 40 gray elective. So these are clinical trials using 40 gray elective. And they were not just HPV, they were larynx, whatever other histologies. So basically, for people to start practicing, 40 gray can also already be established standard of care because you have two trial data, and you are but we are lowering down a little bit further to 30 gray. So I think there's no reason to believe that the 30 gray wouldn't work for HPV negative, but we are running a trial right now. Right, yes, go ahead. Yes. Why not 40? Why not 50? Why you choose 30? Yes, so that's a great question. So I don't know why they chose 40, but the way we chose 30 was that actually it's based on the NIGRO data in anal cancer. Because when they first treated, that was mitomycin, with chemo-RT to the anal cancer that was also HPV associated, they treated 30 gray pre-op, followed by the surgery, and then they saw path CR in the majority of the patients in that anal cancer trial. So that was a long time ago, but that actually served as a basis why we thought 30 gray might work with concurrent chemo, although it's not mitomycin, but it was the same, similar type of cancer. So that's why we decided to go to 30. That's one of the reasons. Another reason is that I did not mention that at Sloan Kettering, we also have a de-escalation trial of gross disease to 30. But that's on a different protocol with close monitoring. So because we figure if we are de-escalating gross disease to 30 gray, then subclinical has to be 30 gray because there's no way you treat the subclinical 50 gray and then you de-escalate the gross disease to 30 gray. So these are the two reasons, but mainly because of historic data, the anal cancer that actually used 30 gray. Right. So I want to move on to another controversial topic of oral tongue. So it's a woman with a history of weight loss and dysphagia and smoking, and this is the example of the exam. Okay. So you can see. All right. So actually, I want to go. No, actually go this one. So this is the oral tongue, long history of tobacco chewing, which we see here. And then, the tongue lesion. Biopsy showed the oral tongue squamous cell carcinoma. So CT showed 3.5 centimeter right oral tongue mass with right lymph node. And then the patient went to surgery, understandably, hemiglossectomy and right neck dissection. Pathology showed a T2, actually actually T3, because of the depth of invasion and extranodal extension. Margins negative, LVSI, no PNI, 3 lymph nodes, ENE, so N3B because of extranodal extension. All right, so this is a very advanced oral tongue cancer with significant depth of invasion, close margin, LVSI, extranodal extension. So what would we recommend? 80-year-old patient. What tests or exams do you order before adjuvant therapy? Okay, one question I want to ask everyone here, is the PET scan covered for everyone post-surgery? Yes? Okay, and do you order a PET scan after surgery as part of your simulation? Not everyone, right? So we find it very useful. And obviously, you cannot order it too early, because if after just 2-3 weeks post-op, you see the post-operative changes. And it's very confusing. So we typically order a PET CT as part of the simulation or diagnostic imaging at least 4 weeks or 1 month after the resection, especially for a large tumor, very bad disease like that. Our paper was just accepted by Oral Oncology, so it's coming up soon. In this population, I think around 20% of them, when you do the simulation with a PET CT, or you can also sometimes see it as CT, but PET CT or MRI, you actually pick up recurrent disease by the time of your simulation, and that will totally change your management. So that's what we have been doing at Memorial Sloan Kettering. Probably you can skip those like T1, T2 small tumors that you are not very worried if there's like a resource or time constraint. But for very nasty disease like this, you almost always want to order a post-operative PET-CT or at least a good diagnostic MRI, because you really capture the recurrent disease, and that will totally change your management. Okay, so then you order a post-operative scan, and then that shows something like this. And this can be a post-operative change, or it could be recurrent, right? And typically when you discuss a case like this at tumor board, surgeons get very pissed off because they say, you know, you are accusing them for the incomplete surgery. It can get really personal. So it really, you know, it depends on, you know, the comfort level of the team. But I have to say, if you have read the scans, post-operative scan enough, you can kind of tell, and also by the exam of the patient. The post-operative changes on the PET tip tend to be diffuse, not particularly bright, coupled with exam, unless the patient had infection or abscess that would make you suspicious. Therefore, if we see something very suspicious, we typically biopsy that just to establish diagnosis. Okay, so that's what we did, and there was no tumor. Is post-operative changes, so we would proceed with the setup and simulation. And this is an 80-year-old patient. How many of them, raise your hand, would give concurrent chemo? Wonderful, yes. So if for a physically fit patient, if without other significant comorbidities, we would push for concurrent chemo because it's a very close margin, and it's just a very poor prognosis. When they recur, they are going to die. So we would do concurrent chemo, and then with the simulation, okay, so with the simulation, we would do the tongue depressing stent, even custom made, or if you have your own mouth bite block, and then they will see the dentist before then. Okay, all right. So for target delineation, again, this is an area of contention. So I can show you the Memorial Sloan Kettering Way, and then the Princess Margaret. So for this patient, it's less controversial because the patient had a really large tumor. All right. So at Memorial Sloan Kettering, doesn't matter how are your tumor sizes. You can be T1, N1, whatever, small tumor, well lateralized oral cavity. The whole mouth gets 60 gray. So at Sloan Kettering, it will be like this. Sorry, shouldn't include the bone. But this whole thing is 60, okay? Because, well, the left neck is not dissected, so the undissected is 56. And then the dissected area is 60 gray. So 60 gray covers the entire mouth, the tongue, the entire tongue, regardless of how well lateralized this tumor is. So the next slide. So it will be like this. All right. 60 gray, levels 1B through 4. And then this one, 56. Oops, like this, okay? So that's the way Memorial Sloan Kettering. However, at Princess Margaret, there's actually data doing more partial tongue radiation if it's a smaller tumor. So that's probably everyone here does, right? So when you simulate a patient, you will fuse the pre-op scan if you have it. So you will outline a pre-op GTV. So suppose this is your pre-op GTV. And then you will do a 0.5 millimeter expansion That's your CTV, 60, okay? And then another PTV. So for T1, T2 well lateralized, this will be your target. The other area is spared. Okay. Surgical bed in the neck, still 60 gray. Okay, and then extranodal extension, you boost to 66 in that lymph node area. And then contralateral, contralateral 50 some gray, 54, 56. So that's a different approach. All right, I think I'm done here. Any questions? We can discuss offline because there are so many differences that I've learned from so many different institutions. When we learn from one institution, we thought that that's the only way until you go to the other institution. They have their only way of treating it. And I think it really depends on your careful evaluation of patients and how they do. Right. All right, thank you.
那我们现在已经都结束啊，对，就现在就吃饭了，然后就是有报名的话，医生都会拿到那个餐。